Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from Romania, Professor Loan Stephen Florian. Professor Florian is currently the head of Department of Neurosurgery at the Cluj County Emergency Hospital and Vice President of the Romanian Society of Neurosurgery, President of the Senate, and Professor of Neurosurgery at the Luliu Hatiganu University of Medicine and Pharmacy, Cluj-Napoca. He is also the president of the Euro Academia Multidisciplinaria Neurotraumatologica, and Professor Florian is a neurosurgeon with most numerous case series from Romania and Eastern Europe, and he has performed over 11,000 surgeries with a vast experience in skull-based lesions. Besides having the largest series of brainstem lesions from Eastern Europe, he also operated the youngest patient with brainstem carcinomas, and he is also a noted author with several publications in various peer-reviewed journals and book chapters. He has also authored highly appreciated book about the treatment of pituitary adenomas. His vast experience and profound clinical insight puts him among the experts in the field of skull-based surgery. We are extremely honored to have him today at our webinars, and today we'll be talking about alternative shunts, ventriculocholecystic shunt. The speaker for the second session of today is our honorable guest from China, Professor Peng Yong. Professor Peng Yong is Associate Professor in the Department of Neurosurgery, 2nd Xinghua Hospital of Central South University, Changsha, China. His clinical interests are focused upon endoscopic endonasal operations for pituitary tumors and other skull-based lesions, endoscopic operations for spontaneous intracerebral hematoma, hydrocephalus, and traumatic brain injury. He has performed over 700 neuroendoscopic surgeries, and we are extremely honored to have him today at our webinars. And today he'll be talking about surgical margins in endoscopic endonasal operations for pituitary neuroendocrine tumors. The chair for the first session is a distinguished faculty from Egypt, Professor Khalid Basim. He is the head of Department of Neurosurgery, Division of Pediatric Neurosurgery at the Cairo University, Egypt. He has a vast experience in the treatment of neurological pathologies of pediatric neurosurgery. His vast experience in the management of pediatric hydrocephalus with alternative shunts, especially ventriculocholecystic shunts. We are extremely grateful to him for accepting our invitation to chair the session of Professor Stephen Florian. The chair for the second session of today's webinar is our honored guest and my dear friend from Italy, Professor Alberto Felletti. Professor Felletti is Associate Professor of Neurosurgery at the University of Verona, Italy. He is a very important member of the ACNS and heads the Alumni Division of the Fujita Alumni Association. His expertise is focused upon the management of endoscopic procedures, especially pituitary and other skull-based tumors. He is a noted author who has published several articles in various peer journals. We are extremely grateful to him for accepting our invitation to chair the session of Professor Peng Yong. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Bun Seng from Malaysia is my co-host for today, and with that introduction, I would like to hand over this online podium to our first chair, Professor Khalid Basim.
Well, I'm really honored for this occasion and to be with just distinguished colleagues and about such a very tough topic that we are all fighting with. And I heard the introduction about Professor Florian, and it's really impressive. I think the problem with shunting is we expect the peritoneum to be always obedient like a slave. Whenever you put a shunt in, it should work. Well, this is only in fiction, but actually many problems happen, and oftentimes the peritoneum will just refuse to work, whether with cysts or without cysts, whether with signs, with ascites, with leak. It simply doesn't work sometimes, mostly in very young children, and then you will be forced to look for another alternative, and the alternatives are not so many. And certainly one of them is the ventricular gallbladder shunt. I started putting the gallbladder shunts back in 2000. I think I have put more than 100 since then. And my experience is not full of flowers. There are problems as well with the ventricular gallbladder shunt. So I'm really interested to hear to my colleague, esteemed colleague, Professor Stephen, about his experience doing the ventricular gallbladder shunts. Please, Professor Stephen, you can proceed.
Thank you very much for the invitation again. I'm really honored to be here and to share part of my experience that started in, at least in pediatric hydrocephalus, three decades ago, when I was resident in the Department of Neurosurgery in Bucharest, along with Professor Ciurea, a very well-known pediatric neurosurgeon. At that time, he asked me to make a review regarding the shunts. And that was the moment in which my interest in this field started. At that time, I collected more than, I think, 200 types of shunts. So that was in 1991. And since then, not only the shunts and devices improved a lot, but also the sites where the shunts can be placed. As already it was mentioned, this pathology, the hydrocephalus, has no, up to now, physiological solution, because we don't know. First of all, we don't know too many things about the physiology of the CSF production and flow. It was stated many years ago, more than 1 century ago, that there is a third circulation, and Cushing was the one who developed this theory of the third circulation. But in the last 2 decades, we know that it's not really as such. There are much more and more complex mechanisms, physiological mechanisms, that are involved in the CSF production and resorption. That's why we have some cases with a very good tolerance to the hydrocephalus, and the others with a very low tolerance to that. This interest in the field, I also transferred to my students, now residents or even specialists in neurosurgery. And this specific presentation was made along with my former students now working outside of Romania, Adelina Prișcu. Now she is working in the Indiana University Health Board Memorial Hospital in Indiana, USA, and mostly my dearest student and resident, Cezar Octavian Moroșanu, who really developed a large interest in this on this topic. Along with them, we made some reviews and published some papers. I will briefly present them in the following slides and minutes. So for today, I will present some historical landmarks regarding the alternative shunts and regarding the CSF biliary diversion. What are the basic principles, pediatric hydrocephalus, in adult hydrocephalus, and outcomes. Generally speaking, the ventriculoperitoneal shunt is the most common shunting procedure performed for the treatment of hydrocephalus, but in less than 80% of the cases, there is a VPS failure. So, along with, we don't know in all cases what are the causes of these failures, but certainly there are some instances in which we have contraindication. So we have to choose another site for the diversion, and the most frequently used are the atrium and the pleural cavity. I perform in both of these places, but for me, pleural cavity does not represent a solution, at least for the moment. And the the last I will refer is the gallbladder, and this is a potential alternative for diverting CSF, and it was introduced by Smith in 1959. In order to avoid to discover America every day, I always, in my presentation, I make I underline some historical landmarks in different topics I present. In this particular topic, I will start with Alexander Monro Secundus, the one who also described the foramen of Monro, and he made the first, one of the first puncture of the AVD, external ventricular drainage, and he mentioned that this could be made in a place there is no danger for wounding any large artery or venal sinus of the head. Benjamin Hill punctured the lateral ventricles through the fontanelle, but he mentioned in his publication that has been followed with so little success that is not generally recommended, even as a last resort. And this was an experience he extrapolated from the other cavity collection, like abdominal collection and ascites and other pathologies. But I, as a Romanian citizen, I'm very proud to mention that Nicolae Turnescu, the founder of the medical school and the Faculty of Medicine, the first dean of Faculty of Medicine in Bucharest, in 1856, published a successful surgical treatment for hydrocephalus. In fact, he performed an external drainage associated with iodine instillation, and this was the second ventricular puncture in the literature at that time. It was published in Bulletin Official in 1856. So Wernicke used the first sterile external ventricular drainage in 1881. William Keane introduced the first recorded access to the ventricular system of a living patient, and he described the Keane's point, which is nowadays quite frequently used. And Theodor Kocher also advocated a ventricular puncture to a different hole, the so-called Kocher point, which is mostly used in the EVD nowadays. There are other attempts to deviate the CSF from the enlarged ventricle to a different location. And the first in the literature were the ventricular subcutaneous drainage. And the one who introduced this technique was Jan Mikulicz-Radetzky, a Polish surgeon, who inserted a nail-shaped mass of glass wool in the lateral ventricles. And in 93 years later, he developed a gold tube for the subcutaneous drainage. Nicholas Sten was the first who used a perforated rubber tube for subcutaneous drainage, and Fedor Krause, whom I consider the pioneer of the modern neurosurgery, a German neurosurgeon, modified the Mikulicz technique and introduced a longer glided silver tube in the ventricle and the outer placing subcutaneously. There are other intracranial deviation, other sites. Intracranial deviation was another solution chosen by the surgeon in history, and in more than one third in 1908, Aschoff introduced the Anton and from Bremen proposed the puncture of the corpus callosum. Then they performed, placed a rubber tube through the obstructed sylvian fissure in an obstructive hydrocephalus. And he also, 2 years later, performed the open third ventriculostomy with the temporal approach to the third ventricle. Scarf and Stuckey performed the anterior ventriculostomy through lamina terminalis, a technique that we are using nowadays quite frequently, combined with the fenestration into the prepontine cistern, and a technique that was available for more than half a century was introduced by Torkelson, the so-called Torkelson technique. It was in fact a ventriculocisternal shunt rubber catheter to divert the CSF from the lateral ventricles in the cisterna magna in obstructive hydrocephalus in the pineal region and the fourth ventricle. Other attempts were made in order to deviate the CSF into the bloodstream. Erwin Peyer proposed the ventriculo-sagittal drainage, and later on he introduced the connection between the lateral ventricles and longitudinal sinus jugular vein. He was the one, he used the jugular vein for the drainage. McClure also used the jugular vein by means of a transplanted vein, and Heines performed the drainage of the cisterna magna into median venous systems. Harvey Cushing presented a drainage of CSF into the bloodstream by silver tube from the dilated third ventricle to the corpus callosum directly into the longitudinal sinus. The spinal drainage was also proposed since the 19th century. The Kinke improved the technique of the lumbar puncture using a special cannula, and Ferguson made a very nice technique. He resected the fifth lumbar arch, drilled a small borehole through the body of the vertebra into the peritoneal cavity, and established a connection between this space and the spinal canal by a loop of silver wire. And Nicol in 1898 connected the free edge of momentum with the spinal dural defect, and also later on he proposed the temporary use of a rubber tube in order to make this connection. So other ventriculospinal spinal lumboperitoneal tentatives were made by Cushing. He slightly modified the technique of Ferguson, and in 1918 the highly connected the spinal canal with the peritoneal through a rubber tube. Leo Davidov, he is a prominent figure in the field. In 1929, he proposed a lumboperitoneal shunt with connecting a strong-walled epithelium line autogenous tube prepared from the patient's own skin. And Ludenik introduced the lumboperitoneal petticoat shunt. The new era started with Walter Kausch. He performed in 1905 the first ventriculoperitoneal shunt, and William Cohn was the one who reviewed the ventriculoperitoneal shunts in clinical practice and published the largest series of ventriculoperitoneal valveless shunting. And Ira and Jackson and Songrass made the first study to compare the ventriculoperitoneal shunts and lumboperitoneal shunts. So coming back to our main topic, in 2018, we published review from the literature along with my coworkers, and we reviewed all the sites where the CSF was placed, and we find in our publication in neurosurgical review, we find different categories. We categorize them in intracranial and extracranial, and those extracranial was classified in intracavitary shunts, epithelial duct shunt, vascular shunt, osseous shunt, in uterus shunts, and also pericranial deviation. So in this table, you see all the sites and the publication. We find epithelialized duct shunts, ventriculoureteral shunts, ventriculosalpingeal shunt, ventriculocholecystic shunt. This is the main topic for today, introduced by Smith, and many other. I will not insist. You can see, if for those interested, you can see the code. You can make a photo of the code and have an direct access to the publications. So, resuming our publication in the field, you may find that we have a quite interest not only in the theoretical part of this, but also in the practical one. And we published our experience in the different kind of deviation of the CSF. One of the, I considered very useful and interesting, we published is the ventriculocisternal shunt. In fact, it's an intracranial, subdural Torkelson method modification, and we published that in 2018, and I perform it in some cases in which I could not remove completely the tumor in the pineal region and upper vermis. So with this deviation, we connect the third ventricle with cisterna magna, and then from there it was absorbed in the bloodstream. So the cases were, maybe I was lucky, but the cases were with a good outcome. Along with some of my colleagues from Bucharest, general surgeon and another neurosurgeon from Bucharest, we also developed a new technique, the ventriculoepiploic shunt, in which we introduce, in the cases in which the peritoneum was not compatible, we perform an introduction into the layers of the epiploon, and this is also a good alternative for cases in which the peritoneum it's not available. It's not a good host. These are the list of the cases, along with my colleague from Bucharest, who perform, and in majority of the cases the results were quite good. We also tried this ventriculovesical shunt, but along with one of my friends, urologist, we were very pleased when we introduced this catheter in the urinary in the blood, and I do not realize that even in repose, the internal pressure of the urinary vesica, it's higher, much higher than the pressure in the ventricles. So in this particular case, the shunt doesn't function a lot at all. But I found in the literature some cases, and I also, along with my colleague with Cesar, we published a letter to editor regarding this technique. So we also reviewed in the literature all the ventriculocholecystic shunt, which are published up to now in the literature. We can find this ventriculocholecystic shunt in different names: ventriculobiliary shunt, ventriculogallbladder shunt, or ventriculocholecystic shunt, and this is the name I rather prefer for this kind of deviation. And we made the research in the literature to determine the current status of ventriculocholecystic shunt. I have to mention that I only performed this technique along with a general surgeon in 2 cases. I don't have the experience of our professor from Cairo, and that's why I made the research along with my colleagues, younger colleagues, to see what is the experience with this kind of ventriculocholecystic shunt. And we made a large research in the literature, and at the beginning we identified on different databases 146 publication, and at the end we resume at 34 studies in our final study, and from these 34 relevant articles, there were a total of 170 patients, 111 pediatric patients, and starting from the 1959 up to now, the largest publication in the literature was of Ketov et al. In 1997, a series of 16 cases. So the distribution in the global distribution of this kind, based on the publications we found, were the largest series were in the United States of America, and some of the United Kingdom, India, Germany, Chile, Saudi Arabia, and some other few cases in the Latin America. So regarding the technique, the upper part of the drainage is a standard one, and the proximal catheter is placed in the fourth or frontal horn through the very well-known technique, and the abdominal incision, it's made in upper right quadrant of the abdomen between the costal margin and the lateral margin of the rectus abdominis. Some authors report laparoscopic approach and tunneling device to bring the shunt into the abdominal incision. The distal end, it's placed in the abdominal cavity, gallbladder, it's mobilized, and small incision, it's performed on the dome of it, and the shunt, it's inserted for 3 to 7 centimeters inside the gallbladder, and there are sutures in order to occlude and to fix the distal end. At this side, additional suture in order to avoid retraction from the gallbladder are introduced, and the redundant tub it's left in the peritoneum. So from a literature perspective, the ventriculocholecystic shunt insertion was performing as a primary attempt in 4.2% of the cases. The majority were as a second or third solution in order to solve the ventriculomegaly or hydrocephalus. But the rate of complication we found in the literature was quite high. 44% of the cases published up to now presented some kind of complication, but the complication should be interpreted with caution as there are multitude of follow-up timelines. So as a discussion, we refer to the physiology, indication, contraindication, and complication. Regarding the physiology, the patency of the ventriculocholecystic shunt relies more on the eliminating. It's the cholecyst is only used as a conductor of the CSF to the digestive tube, and it's not considered that gallbladder has an absorptive capacity. One of the major concern it's related to the side of the gallbladder, and a small gallbladder could accommodate less CSF, and intrinsic pressure. Another problem of the biliary tree, it's adds 10 to 20% centimeter or water resistance to the shunt system. So a low pressure or a programmable valve set to low resistance, it's indicated. And the pressure is also influenced by the gastrointestinal motility in postprandial period. So the indications are not routinely performed, mostly as an alternative after failure of the ventriculoperitoneal or ventricular atria. The promising result based on the literature we found as a first-line treatment, it's in congenital plasminogen deficiency, optic chiasmal hypothalamic astrocytoma, and the post-tuberculous hydrocephalus. Contraindications are related to any biliary pathology, absence of the gallbladder because of the previous cholecystectomy, biliary infection, and predisposing factor to cholelithiasis, like hemolytic anemia, sickle cell disease, hereditary spherocytosis, and gallbladder sludge. It's also an contraindication. So complication, there are some general complication. 37 to 43% of the cases in the literature, obstruction in 10%, infection up to 31%, and the specific complications are death secondary to biliary ventriculitis, published in 85 by Bernstein, bile peritonitis due to catheter fracture, gallbladder atony, cholangitis, and cholelithiasis, and MRSA ventriculitis as a secondary infections of the system. So in conclusion, hydrocephalus can be a challenging pathology. Thus, it is important for a neurosurgeon to be aware of all the available therapeutic avenues. The ventriculocholecystic shunt has been reported to be a feasible option in congenital plasminogen deficiency, optic chiasmal hypothalamic astrocytoma, and post-tuberculous hydrocephalus. This shunt cannot be viewed as a first-line strategy, as there are still aspects regarding the indication, contraindication, and follow-up that require clarification. Some authors advocate for the ventriculocholecystic shunt as an early alternative. However, further research with larger patient population is required. For more information, you can make a photo on this code, and you can see our publication, last publication in Neurosurgical Review. These are the references we studied, and thank you for your attention.
Well, I'm really impressed with how elaborate and detailed your presentation, Professor Florian, was. I was really, I'm happy with the presentation, and particularly that you insisted to describe every step of those who preceded us. Because up till now, as you said, we don't understand why ETV fail, for instance, why CPC fail. There are many questions, and we still don't understand. So every step that has been done before us will give us one clue, or at least close one door in our pursuit to find a solution to this devastating problem. So I really congratulate you for this nice presentation. And so now, if any has actually, since I have done so many cases of this procedure, I may add a few points if you allow me.
Yes, please, because I was impressed when I heard that you performed so many, but
yes.
I couldn't find it. I don't know why.
Well, actually, I'm lazy in publication, but my center, we do every year about 700 to 800 VP shunts, and of course, as you know, the failure is very high. We expect failure about 50% of children in the first year. So at least we have 300 shunt failure per year. So I started doing them back in 2000 when we have a patient who had peritoneal failure, and the jugular veins were obstructed because of previous cannulations. And I was stuck in the OR. I couldn't figure out where to go. So I called the author of one of the articles. He published this in 1986. I called him personally. I told him, I'm in the OR, I'm stuck, I don't know what to do. So he described for me the technique that you presented in your paper using a connector and stuff. And this was in the year 2000. Since then, I have been doing every year about 5 to 10 cases of this procedure, and I learned it to my residents. And now it is being widely used. In the beginning, I was very happy with the procedure. I thought this will be the solution, and all our problems are gone. But then over time, problems started to happen. Some of the problems are related to the technique. If you are not very accurate while doing the purse string suture and placing the connector, biliary leak is a fatal event, and so the patient is gone. Sometimes if the shunt has no valve system, as you said, the bile will flow upwards and will destroy the brain. The rate of infection of ventricular gallbladder shunt is similar to the ventriculoperitoneal shunts, about 10%. But I found many problems. For instance, one of the problems is that I found that the gallbladder is not a site of drainage; it's a site of concentration. So all the liver juices are collected in the gallbladder, and the sphincter of Oddi closes strongly, and it keeps concentrating the juice till it becomes very concentrated, and then open and let it go. So what I found is that in young children, the sphincter of Oddi can raise the pressure to about 20 to 25 centimeters of water, and this will be reflected on the brain. The ventricles will be moderately enlarged, the pressure will be moderately enlarged, and the skull, the head will keep on growing, but in a mild form. So actually, in the recent years, I stopped using the gallbladder shunts for young infants because of this problem. It is not sludge, because you have 100 or 200 cc's of fluid going through the gallbladder. So any sludge will be cleared. But the problem is with the sphincter. The sphincter tends to cause a back pressure, particularly young infants, that may affect the function in young children. So nowadays, actually, I'm not very enthusiastic about using the gallbladder shunts because of this particular problem, because at pressures of 20 to 25 children below 1 year of age, you will affect their brain development and you will affect their milestones. So, but after age of 1 year, it works, not completely. Sometimes I have been very disappointed for unknown reason. You put the shunt in and it doesn't work. We don't know why. As you said, the complication about 40 to 50%. And this is what I found now. That's why also finding a gallbladder, sometimes it is difficult. In my first case, I asked for a general pediatric surgeon. He helped me to find the gallbladder. But afterwards, the rest of the cases I have done them on my own. It's not difficult, actually. But the problem is that you need to do ultrasound before proceeding to surgery, because 4 out of every 10,000 children, they don't have a gallbladder. And it will be a catastrophe if you open the abdomen and don't find the gallbladder. The gallbladder location is variable. Sometimes it is shifted to medially, sometimes shifted laterally, and then you open. Sometimes it is large, very superficial. Sometimes it is very deep. So doing an ultrasound before proceeding will help you significantly to feel assured and to make a smaller incision directly over the gallbladder and then take it out and then end the procedure. So the procedure is not difficult. You can do it without a pediatric surgeon after the first case, provided that you do an ultrasound. So you will ask me, so what are you doing now? Because we have this tremendous flow of peritoneal failure rushing over our head continuously. Well, I think the major difference in our management was in 2014. In 2014, because we do 600 cases of shunts every year, 20% will have peritoneal failure. You put the shunt in the peritone and it failed to absorb the CSF without infection, without cysts, without ascites, without leakage. And then at that time, we were doing a lot of gallbladder shunts and atrial shunts. Atrial shunts is a big problem because it is devastating to the children, and it can damage the lung, it can damage the kidneys, and many times we have atrial thrombosis. And so in 2014, we found that if you put the shunt in the suprahepatic location, our incidence of distal peritoneal failure dropped significantly from 20% to almost less than 1%. So now we have every year 6 to 10 cases only of peritoneal failure. And this is an occasion to share with you my experience in this point, is that putting the shunt with a trocar above the liver will save you a significant amount of peritoneal failure. So this is one point. But sometimes we still have peritoneal failure even with suprahepatic location. But now it's in the range of 1 to 2% of cases. So now we are still stuck with this problem. Recently, I've been doing CPCs with increasingly number of cases. And CPCs, according to the literature, success now is around 30 to 50%. But we added some modification to the procedure in the form of irrigation drainage after performing the CPC. And it seems that our success is getting higher, approaching 70% in most of the cases. Another alternative, because sometimes you go in and you find that the veins are thrombosed. And also, this is advice to our colleagues. You don't do a ventricular atrial shunt without performing an ultrasound, because the jugular vein may be thrombosed. And when you open, you will keep looking and you will not find. So this will be very bad condition. So do always an ultrasound before the ventricular atrial shunt or the ventricular gallbladder shunt. Now you will ask me, what are the alternatives? I think CPC is promising. We need to find some clues. Why CPC fail? This is a really interesting problem. If you are cutting out 80% of CSF production, why is this high failure rate somewhere between 50 to 70%? So this is what I'm working on now, trying to find why it failed and how to decrease the percentage of failure. So Besides the CPC is a demanding procedure. It needs a lot of experience with the endoscope, and oftentimes there is bleeding, and then you lose vision completely. There is air, but then there is another alternative I would like to share with you, is the ventriculo-jejunal shunt. As you said, you tried the ventriculo-vesical shunt in the urinary bladder, and I tried it as well. It's very simple to put it, but the problem is water and electrolyte loss. I did it in 4 patients, and they have severe hyponatremia and hypokalemia because there is no absorption. All the CSF with all its electrolytes are pushed outside. So I think 2 of them died because of this problem. So I stopped, of course. And I tried the ventriculogastric shunt. The ventriculogastric shunt is another alternative. It's published in the literature, but the problem is the food chunks are very large and obstruction is very high. So I stopped it as well. But now what seems to be maybe a promising solution is the ventriculo-jejunal shunt. We all know that the jejunum is very long and the contents are sterile. If there is no leak, the wall is very thick, not like the gallbladder. Leakage from gallbladder is fatal. Leakage from the jejunum is nothing. And you can only put a tube in the gallbladder once. You cannot go back again because there will be adhesion. You cannot even see the gallbladder. But the jejunum, you can go again and again and again. You have 6 meters of length. So I have done so far about 20 cases of jejunum, and like 10 or 12 of them are doing quite well with no problem, no complication. I'm just sharing my experience. We are all in the same slot. We are the same camp trying to find solution for these problems. So one option is a ventriculo-jejunal shunt, and simple, easy, very small incision. You don't need any ultrasound, and they work apparently. But you tell me what you are trying, experiencing. Well, we are, when you have the peritoneum filled, you try the gallbladder, doesn't work. There is no veins in the, so you need to have another option. You are not going to close the patient and go home. You need to have other options. So this is an option. Once you have out of any solution, this may be used, and it is simple. And also, I used to put them around a connector like we did for the gallbladder because to avoid leakage. So these are some of my comments on this topic. I spent almost 26 years on this dealing with hydrocephalus. Currently, actually, most of my work are hydrocephalus and cranial stenosis. I'm not doing anything else than these 2 procedures, and I'm very excited about CPC. I hope one day our results will get better and avoid to put shunt at all. So I'm sorry for talking too much, but it's an occasion to share my experience with all of you.
I would like to thank you for sharing with us your experience. It's very useful, and I think it's more important than in less than 20 minutes. You concentrate all the literature I studied in 6 months in order to find a solution. So yes, I also perform, but this ventriculo-jejunal shunt once by mistake.
Oh, okay.
But yes, but the patient went well, and I don't want it to re-enter. I find the during the CT, the control CT, I saw the tube inside. I don't want, and the patient was very well. So yes, it's a solution, and I try dealing with this kind of cases, not in such a large amount like you, but I also deal with hydrocephalus cases in our department, which is a general neurosurgery, and I am one of the neurosurgeons which are dealing with also the pediatric cases. Yes, I'm deeply grateful for sharing with us your experience, your tricks and tips, and I will be very glad to increase our collaboration and our changes in this field. You know, I also have I have in my mind large studies and a preoccupation regarding the post-traumatic hydrocephalus, and I'm in some groups studying this, and for this is also a very difficult solution. The VP shunt, it's okay for a moment, but how to deal with, how to solve it, and at the end, maybe increasing the collaboration in the neurosurgical world regarding not only the surgical solution, but also in understanding the physiology of the CSF. Maybe we together will find a solution. Thank you again for your comments and for your experience.
Thank you, Professor Stefan. And let me add 2 points. What encouraged me to put the shunt in the jejunum, that all of us had patients who had the shunt coming out of the anus. Sometimes it come out and then go in. And the child is doing perfectly well, no infection, nothing, shunt is working. So I said, if it is in the colon and doing very well, so what about the jejunum?
Why not?
It should work. Yes, it should work well. So this was a start.
I also found a case like this, yes.
Another thing is that in doing my CPCs, what I'm adding is that after finishing my CPC and ETV and laminar terminalis, I put 2 tubes inside, one inside the ETV for irrigation, and another one in the ventricle for drainage. And I call it irrigation drainage modifications after CPC. The idea is to push a lot of fluid in the arachnoid space and to open the arachnoid spaces and to push fluid through the absorptive arachnoid villi. And I was amazed to find how these cases can absorb a lot of fluids. They can absorb somewhere between 500 to 1 liter of fluid very easily, the arachnoid. So it is not a problem of terminal absorption. It seems that it is a problem of circulation of the CSF around the brain surface. So these are one more clue. I don't know how this will help to solve the puzzle, but this is what I found, that the absorption is really significant. The problem is the circulation.
Yes.
So we are still working on this problem, because I don't know if you are aware of this recent study from Ethiopia, which was published last year, and they followed 340 patients who had shunts for 3 years, and by year 3, 30% of them were dead. So shunt is not as benign as we think. Shunt is, it's a big threat.
Well, I'm
glad to see Professor Bingshu.
Hello, Professor Florian and Professor Basim. Thank you both. Very interesting presentation. And so I log on and I heard very carefully. And I think we should invite Professor Basim to present his vast experience in this counting. Yes.
Of course, we will.
Thank you both. And tonight we have more than 700 audience in the WeChat channel. They are very enjoyed your presentation. Thank you.
Thank you. Thank you.
Thank you. Thank you very much. We can take 2 quick questions. Of course, our second chair, Alberto, has raised his hand. Yes, Alberto.
Thank you, Raja. So I want to thank Professor Florian and Professor Basim for nice presentation and for the very active discussion. A very interesting topic, because it's a common problem for any neurosurgeon, right? So communicating hydrocephalus is something we encounter daily. At my institution, we use VP shunt as first plan, and we use VA shunt as B plan. And this is probably generally in all my country, in Italy, and in most other countries. Probably in other countries like Japan, they use VA shunt as first choice. But in any case, VA shunt and VP shunt are considered the first choices. So my question is, what do you do at your institutions? Do you reserve these other options as a C plan if both VP shunt and VA shunt fail? or do you use the gallbladder like a B plan or even the first choice in cases, in specific cases?
No, if you allow me to answer the first, we have the same policy in our department. In our country, I think it's the same. So the VP shunt is the first line. The big plan, it's the ventriculoatrial shunt, and this solution we discussed today are the third line options.
And
in ventricular gallbladder or ventricular urinary or whatever, it's recommendable to have a pediatric general surgeon along with you, at least at the beginning, as Professor Bassim mentioned. We are not very familiar with this kind of surgery, and for that, even from a medical legal point of view, it's better to have in your team a general surgeon, pediatric or adult, doesn't matter, but we from our formation, we have the gallbladder surgery, the urinary surgery in our curriculum. So we are not covered if we attempted to put a shunt in that part without having the specialty. So from a medical legal point of view, at least in Romania, in this part of Europe, I think it's the same. It's better to be in a team with a general surgeon for these third line type of surgeries.
Thank you. What about Professor Bassim? You did a lot of these operations. So do you use it at a third line therapy or B plan?
Well, at the third line.
Third line.
Yes. Usually, we used to do VP shunts, first line, and if they fail, we prefer to do VA shunt. However, we explain to the family that the VA shunt, the complications are serious, and they may have atrial thrombi, they may have pulmonary hypertension, the shunt failure, kidney failure. So some family will say, no, that's too dangerous. No, let's go to the gallbladder. So that's now. I would like also to mention that I have done also ventriculopleural shunts, and I have done many of them. And the literature said that you cannot do them below 5 years. So I have been doing them after 5 years, and actually I can say that all cases that I did failed because of ventriculopleural effusion. So actually the pleura is not recommended. It's very easy to be done, but in my experience, the failure is extremely high, not to be considered. However, one more thing is that currently at my institute, we are slowly moving CPC to be considered as an option, as a first-line management in some cases.
Right. Thank you very much, Professor Stephen Florian and Professor Khalid Bassim, for this wonderful topic and beautiful discussion which followed. We are extremely glad to learn so many things from two senior most neurosurgeons. There's a big sachet of information for the young neurosurgeons to read and to follow you both. Thank you very much. So I will go to the second session directly. So I'll hand over the podium to our Honorable Chair, Dr. Alberto Felitti, to say a short introduction and invite Professor Peng.
Thank you, Raja. Let me first say it's always nice to join these educational events. So thank you for the invitation. I also take the chance to say hi to Professor Shubin, my dear friend and mentor. It's a pleasure to see you here. And it's a pleasure for me to introduce the next speaker, Professor Peng Yong, and his lecture, which will cover a very interesting and crucial topic, which is surgical margins in endoscopic endonasal surgery for pituitary and neuroendocrine tumors. We all know that being able to precisely follow the margins of any tumor is crucial. not only because this can maximize the extent of removal of the tumor, but also because, especially for pituitary neuroendocrine tumors, it can minimize injuries to the surrounding structures, and also it can minimize some complications that can occur after surgery if you leave a remnant of the tumor, especially postoperative bleeding. So I am personally looking forward to listening to Professor Peng's lecture, and I invite Professor Peng to start sharing his screen and start his talk. Thank you very much.
Thank you. Thank you, Professor Baladi, for the introduction. And many thanks to Professor Shubin and Professor Raja for invitation. And thank you everyone for being here. Honored to join this webinar. And my topic today is surgical margins in endoscopic intranasal surgery for pituitary neuroendocrine tumors. So as surgeons, we always hope we could achieve safer and more effective surgical results for patients. When I applied endoscopic intranasal approach for pituitary tumors, I always think of the boundaries or the surgical margins of the operation. There has been a lot of evidence and consensus that pseudocapture is the very good surgical plan for gross total resection. And because tumor cells probably invade the capsule, to perform the extracapsular resection, we'll get a better result. An invasion of medial wall of cavernous sinus remains a significant predictor of incomplete surgical resection, failed biochemical remission, and tumor recurrence. So in recent years, I assume one of the biggest advancement of pituitary tumors surgery is the anatomical research of cavernous sinus and medial wall resection under endoscope. So that's improved remission rates in patients with functional tumors and medial wall invasion. So in my practice, I also found invasion frequency is much higher than we realized before. Like this publication from Stanford team report the medial wall invasion frequency is 100% among grade 2 to grade 4 somatotroph tumors. So it is certain that intraoperative inspections and pathological exams are golden standards for confirmation of tumor invasion. But still, there are some indications to identify invasions before surgery. We can see the MRI image of this case show a irregular shape of the tumor with multi-lobulated features, both superior part in the suprasellar region and inferior part in the sphenoidal sinus. And these are strong indications of tumor invasion. So I will present details of this case later. And this case is a real case, a giant tumor and apoplexy. The real growth pattern shows the tumor invade all these structures around. And not only bilateral cavernous sinus, we can see especially tumor growth through the pituitary gland and all the way into the third ventricle. So this is a very real and high-risk case. And we can see the third case is a giant tumor, where its maximum diameter is more than 6 centimeters. But I don't think it's a complex one. We can see the tumor has very regular and smooth shape. And the compressed and displaced gland is around the tumor, has not been breakthrough. So I removed this tumor through endoscopic intranasal approach. The patient did well after surgery. The first one is a young lady with acromegaly. I suggest more attention should be paid to young acromegaly patients. The remission rate of young patients is much lower than that of adult ones. Currently, some studies reveal that there are different pathological features and biological behaviors of these tumors. So the image shows, we can see bilateral involvement of cavernous sinus, confirmed by operation. I will discuss this later. So I believe identifying risky cases before surgery is very important for us to make good plan and achieve more effective results. So let me present some cases, share my experience on this surgery. This is a 53-year-old male presented with left eyelid ptosis with diplopia for 1 month. We can see the MRI scan show a relatively small pituitary tumor, comprising normal gland to the right side and superiorly. And the tumor is close to the capital sinus on the left. We can see this video is unedited, so it's very large. We can see, I'm going to play it fast forward. We can see we get a very wide exposure. Usually I take a U-shaped incision to open dura widely. In this case, the incision is a little bit deeper. The compressed gland, we can see, separate the gland around with the dura. Two-hand manipulation, and I used a disc dissector. We can see compressed gland was separated around. Then I proceed the dissection along with the capsule with help of the suction tube. And we can use a little counterpart to assist the dissection. The tumor is relatively big to this small space. I decided I need to debug the tumor. I sent the tumor to a pathologist, and luckily the capsule is thick enough, so I can use the little pituitary cup forceps to grasp the capsule and to pull down. We can see the posterior margin of the tumor, and then we remove the tumor and block. And we can see it. After inspection of the cavity and the irrigation, we can see the middle wall of the common sinus very clear and intact. So in this case, I think the middle wall of the common sinus do not need to be resected. So the patient recovered well and no complications, and had very perfect image, post-op image. So for another case, I performed extra capsule resection and minimal of common sinus resection. And this is a 30-year-old female, malaria for 4 years, and decreased visual acuity for 6 months. And he can't tolerate the side effect of medication, and we can see lab test, his prolactin is 200, and we can see the tumor has subclinical hemorrhage, and it's close to the right, it's close to the common sinus on the left side as well. Okay, we use U-shaped incision and wide open of the dura. And when we face the venous bleeding from the common sinus, we use surge flow to packing the common sinus. We elevate the dura, and we can see a broad exposure of the tumor cavity. And we use curate and suction to debulking the tumor. And then after enough debulking, I can use the disc dissector to see the to dissect the capsule. We can see the two layers of the tissue, two layers. The inner layer, I believe it's the capsule. Then I dissect along the normal gland here. Then we take out the capsule and we continue inspect the capsule around. We could find the complete capsule in inferior and on the left side. Then I start to expand the resection. Then I cut open the cavernous sinus, and we face the venous bleeding from the cavernous sinus. I use a surgical flow to packing, and after packing the cavernous sinus, we could get a clean surgical field. Then I dissected the medial wall and transected the inferior paracella ligament. From the carotid artery, and then continue separate the medial wall. I use a gel foam to protect the carotid artery. We can see separate the medial wall of into cavernous sinus all the way to the right side. I cut it from the right side. Then this is the last transection. Then I can take out the whole medial wall of the cavernous sinus and in the cavernous sinus. Okay. So this is the view of after resection, and reconstruction is very simple, and it's in routine way. And so patient did well postoperatively with no complications. Menstruation is normal during phone follow-up, and tumor cell was detected in the medial wall of cavernous sinus in pathologic exam. So here are some personal recommendations for relatively low risk pituitary tumors. To maintain the first, we need to maintain the operative field clean and clear. And secondly, sufficient exposure and manual microsurgical manipulation is very important. Then when the tumor capsule is complete, try to separate the long extra capsule as much as possible and remove the capsule. When the tumor capsule is incomplete, the surgical margins should be expanded according to the situation. And to dissect along the displaced normal gland and the posterior aspect of tumor margin, macroadenomas. That's the tip to find the tissue interface to perform extra capsule dissection. And let's talk about some invasive tumors. This is a 59-year-old female. We can see physical examination revealed incident pituitary tumor for 20 days. Lab test show she has a high growth hormone and IGF-1 and prolactin. And MR imaging demonstrate tumor invade the left cavernous sinus, especially in the superior compartment of the cavernous sinus, and partially encased the carotid artery, and displace the pituitary gland to the contralateral side. And let's see the intraoperative findings. Again, I prefer U-shaped incision, wide open of the dura, and then I put up the dura, and then we get very broad exposure, and to start debulking the soft tumor. After debulking, I get enough space for further dissection, I'm going to search the tissue plan. Of course, the earlier identification of carotid artery with microdoppler is the key to keep the operation safe. And I started the dissection via posterior margin and along the interface of compressed gland. We can see this is the capture of the tumor, and then we can see the normal gland is here, and I proceed the dissecting. And the capsule is sticky enough, so I use the cup forceps to pull out the capsule. And we can see the alkaloid membrane there. And the capsule is incomplete. In the left side, the tumor is goes into the common sinus. Then I decided to resect the middle wall of the common sinus. First I transected the inferior parasite ligaments. And then posteriorly transected the parasite ligaments as well. I use a pad to protect the carotid artery. We can see here is the medial wall. Then I remove it. We can see here is the posterior lobe. We need to be protected, which need to be protected. And I would take out the medial wall. And then I get into the superior compartment of the common sinus to resect the residual tumors. We can see there are some tumors there. Here I take the endoscope inside. And I also inspected the inferior compartment and the lateral compartment to see if there is any tumor invasion. Turns out there's no tumor there. Then again, I get into the superior compartment to inspect it carefully to see if there's any residual tumor. And this is the last view of the surgery. We see a very broad, very expanded resection of the tumor. And again, I inspected, use a piece of fat graft for construction, and then a Duragen 2-layer, and gel form, and then balloon to support and pack in the sphenoid sinus. It's the end of the surgery. So the patient recovered well after surgery, only 2 days of diabetes insipidus, no other complications. And she got complete biochemical remission and pathological diagnosis revealed the pleural hormone tumors. The tumor cells are detected in capsule and middle wall common sinus. We see another very invasive somatotropic tumors, and this is a young lady with high growth hormone and IGF-1, and the tumors invade bilateral common sinus and push the pituitary gland upwards. Now let's see the intraoperative video. Again, I use the same procedure, just like previous one, debulking, extra capture, dissecting. We find the tissue plan here, the normal gland, the capsule. On the normal gland, we can always find a tissue capsule there, and we can see the tumor was found to grow outside the capsule. Use forceps to pull out the capsule. We can see there's an interface here. And we cannot take it as whole, so we take it peacefully. And then we inspect the common sinus on the left side. We see the tumor invade the common sinus, and the capsule is incomplete. So we decided to open the common sinus, and we can see the assays here, and we dissected the ligament, and then we cut the parasite ligament to separate the medial wall. Again, we identified the course of the carotid artery, and we proceeding the dissection cut the medial wall with the dura here. Then we get to the contralateral side, and we again we opened the common sinus on the right. And we can see the tumor, amount of tumor. The consistency is a little bit different from the tumor inside the cell. And we use dissection technique to remove a tumor. And we open the anterior wall of the common sinus to make sure there is no residual tumor in the inferior compartment. So we cut all the structures around the tumor, including the medial wall and the durus of the cell. So that's the last view of the surgery. We can see bilateral common sinus explored, and the posterior lobe of the pituitary gland and the anterior lobe. So that's the end of the surgery. So we can see the patient got very well recovery and no complications, biochemical remission day 1 post-op, pathological diagnosis somatotroph tumor, and again, tumor cell detected in the capsule and middle of common sinus. Here are some personal recommendations for high-grade nostril tumors. First, we need to take good advantage of endoscope, especially the lightening and the magnification inside, and good hemostasis and appropriate packing of common sinus. And careful inspection of boundaries between tumor and the middle wall of common sinus, especially when the pseudocapsule is incomplete. For high-risk functional tumor, surgical margins are likely to be expanded. Another type of high-risk tumor is irregular growth tumors or multilobulated tumors. I believe these tumors are highly invasive, and capsules are not be detected for many cases like this. MR imaging shows this tumor breakthrough supracellular membrane and cellular floor inferiorly. Let's see intraoperative findings. We can see the tumor was highly invasive and invades into the sphenoid sinus only covered by mucosa with bone absorbed. I take out the mucosa, I start debulking, and open the dura widely. I use the curate and the suction to remove a large amount of tumor. We can see the tumor on the supracellular region, and we cannot it cannot fall down. Then I open the dura of tuberculum. Again, I use curate, but still the tumor cannot fall down with supracellular membrane. We use two suction technique. Then I switch to the 30-degree endoscope, two suction technique. We can visualize the structures, the relation between the tumor and the optic apparatus. I start the two-hand microsurgical dissection, and this is very meticulous manipulation. So I'm very careful and attention to the carotid artery on the left. I try to keep the liquid membrane intact and to avoid injuries to perforators. Then we can see a little tumors there attached to the liquid membrane. So I use two suction technique, and this is the last view after surgery. And this is a high flow accessibility. I use Duragen, a piece of fat graft, and then this is septal flap for the construction. The patient has suffered a visual field defect in the early stage, and no CSF rhinorrhea or meningitis, and discharged at day 7 post-op, and the visual field recovered at 1 month post-op. So, but the pathological diagnosis is silent corticotrophic adenomas. You can see the TP is a positive for IHC. So another one is very highly invasive case. Last case I want to share, and it's a 56-year-old female presented with headache and CSF rhinorrhea for 7 days. Preoperative exam shows no neurological deficit. Only CSF test revealed mild meningitis. And MRI scan demonstrate very giant tumor with very broad invasion, almost the whole sphenoid sinus and all the compartment of common sinus on the right side. And we can see the pneumocephalus on CT scan. And let's see the intraoperative findings. This type of tumor with scalp-based invasion, bone absorption, and the tumor only covered by mucosa. We cut open the mucosa. We start the debulking. The strategy of this operation is to maximize the tumor removal as many as we can. And first, I remove a large amount of tumor inside the sphenoid sinus. Start with inferior part. We can see tumor in the clavicle recess, the inferior part, and the mucosa along with the tumor. The dissection technique is very useful for me to keep the surgical field clear enough. I can identify the critical structures. We can see a lot of blood from a lot of bleeding from the tumor, bone, and the common sinus. So we need to control the bleeding simultaneously. This is the lateral recess of the sphenoid sinus. And we take out the mucosa with a lot of tumor. This is the lateral recess. And then I'll take out the tumor in the cellar region and tuberculum cellar and the mucosa. And we can see a good surgical landmark is the optic canal, which is visualized there. And we can see the CSF leak point here. And I wanted to create more space, so I start to remove the tumor inside cellar, and we can see the compressed and the displaced normal gland, all the way to the left side. Then I remove the tumor in the superior compartment of the common sinus, all the way to suprasellar region. We can see the suprasellar space. And after resection, we use gel foam and cotton pad. We try our best to resect the tumor inside the suprasellar compartment. Then the inferior compartment of the common sinus. And the lateral compartment, we can see a lot of blood flow out. And we use 2 suction techniques to maintain the surgical field clear. Then we can see the 6th nerve here. And last piece is the anterior wall of common sinus. I dissect from the carotid artery. And I dissect it and remove. And this is the last view of the after removal. We can see the whole segment of the 3 segment of the internal carotid artery, and which is intact. And we use a piece of fat graft to reconstruction and surgery cell. And we use Sturgeon for the second layer. And then there's a septal flap. Well, that's the end of the surgery. So the patient got very well post-op with no neurological deficit, no CSF rhinorrhea, and recovered well with antibiotics for treating meningitis. And the pathological diagnosis is silent cholecystrophy adenomas again. So we can see the post-op image is very satisfying. So here are some personal recommendations for highly invasive tumors, pituitary tumors. First, we need to distinguish high risk tumors before surgery. And when tumor grows irregularly and is invasive, expanded exposure is required. And for highly invasive tumors, earlier control of internal carotid artery to keep operation in safe zone is very important. And protect the arachnoid membrane as possible when tumor invade the suprasellar region. So let's get to a summary. And the pituitary neuroendocrine tumors exhibit very invasive growth. When we make surgery preparations, we need to distinguish high-risk cases. Intraoperatively, take good advantage of endoscope to get better visualization. And the clear surgical field cannot be emphasized more to get good surgical results. And the pseudocapsule and the middle wall of common sinus are good surgical margins. And always try to dissect the tissue interface. And the treatment of these pituitary tumors with widespread invasion is very challenging. The surgical techniques like the endoscope and expansion of the surgical approach do not change the pathological entity of very aggressive tumors. So that's the end of my speech. Thank you very much.
Thank you very much, Professor Peng, for your brilliant results and very interesting presentation. I think I totally agree with your tips and tricks. I strongly believe it's crucial, important to follow the capsule and perform a extracapsular dissection whenever possible. Of course, the invasive tumors are the most tricky, the most challenging, and this is the most interesting part, I think, of your presentation. In those cases, we need extended approaches very often, and we need enough experience to manage potentially catastrophic events like carotid artery injury or also CSF leakage postoperatively. So I have some questions for you just to introduce the discussion at this point, and maybe we can have also other opinions among the audience. Do you perform this kind of surgeries by yourself, or do you have an ENT with you, especially for the approach? This is my first question. The second question is, in invasive tumors, do you think or do you believe there is a limit beyond which it's better to avoid going and maybe refer the patient to radiosurgery for a small remnant, for example? Or do you try everything possible? Of course, we have to do everything to remove, to obtain gross total resection. But my question is if you think there are some limits that should not be crossed because of the balance between benefits and risks. And third question, as we are talking about margins and the need to chase the margins of the tumors, even in very risky areas like cavernous sinus and around the carotid artery, internal carotid artery. So in those patients, when the carotid artery is encased by the tumors, have you ever experienced an injury of the carotid artery? And what's your strategy to manage intraoperatively these cases? Thank you very much again, Professor Peng.
Thank you. Thank you for your last question. And first question I remember is that we do I've performed nearly 700 endoscopic endonasal surgery for for lesions of salary region, and almost all of them I do it only by neurosurgeons without the help of ENT surgeons. In China, most surgery was done by neurosurgeons. This is the first question. The second one is of course, we may have residual tumors and remnant, especially for the highly invasive tumors. And a lot of tumors with a highly invasive nature and aggressive ones, we cannot resect all of them. So radiation, radiotherapy is a very good therapy for and for most of the cases, I would recommend the patient. There are the two scenarios. First, if the pathological result shows the tumor is highly invasive with mitosis and very high Ki67 index, so I would recommend this patient to the radiologist for further therapy. So if the tumor is not that invasive, I would recommend the patient for further follow-up, image follow-up. And this is the second question. The third one on the encasement of the carotid artery. So the first, I believe the most important is to avoid the injury to the carotid artery. That's the most important. So for last 5 years, I never encountered the injury to carotid artery. I perform around 100 cases per year. So maybe I'm not lucky, but I have some tips to avoid the injury to carotid artery. First, we use we need to distinguish the very high risk tumors before surgery. Secondly, we used microdoppler to guide the surgery to to protect to know where is the safe zone of the operation. Thirdly, we are very careful when we use the sharp dissection or the scissors when we are close to the carotid artery. But for pituitary tumors, I don't think it's you need to be very careful of the the branches of the SA, like the inferior the hypophyseal artery and the manager the trunk of the branches. So you need to be very careful. So if you face the injury to the RCA, I think there are a lot of measures to repair. You may packing the endovascular repair and or the suture. Some surgeons use this suture under the endoscope. So I don't have many experience on this. So I mean the most important is to avoid the injury to the carotid artery. So thank you.
Yes, thank you very much. I agree with you that it's important to study before entering the OR, study the case and identify the high-risk patients and be ready for, having everything available with you, like the microdoppler is essential in high-risk cases. I totally agree with you. So I would like to ask the audience if there are questions for Professor Peng.
So far, we do not have one in the chat box, but I would like to ask one question that in extended endonasal approaches, does Professor use lumbar drain?
I really use lumbar drain for surgery or for the avoid of CSF leak. I really use it, but I recommend the use in meningiomas because the reason why, because I can't, especially the meningioma of tuberculum sella, I don't think we can pack too tight on the skull base. So I need to use the lumbar drain when I resect the meningiomas of tuberculum sella, because we open very rapidly. We open the optic canal very rapidly, very broad. So, but we cannot use too many materials to packing that area for avoid the compress to the optic nerve. So I just use Dura and the septal flap to repair to come to reconstruction. So I will use the lumbar drainage. But for pituitary adenoma or craniopharyngioma, I don't use lumbar drainage at all. No, thank you.
Thank you very much. So in that case, we can wind up. We'll hear the final remarks from Alberto.
Yes, Raja, thank you. We focused on margins of tumors on pituitary neuroendocrine tumors today, and Professor Peng showed us very impressive cases from which we could actually learn some very precious tips and tricks to follow these margins and minimize complications. And also, when you are not able to follow the margins with the extra capsular dissection, how to manage these invasive tumors. As we said, it's very important to study the case before in those very tricky cases, understand where complications can rise from, and be ready with proper instrumentation first, and also to be able to perform the correct maneuvers. Professor Peng stressed a lot about being careful and avoiding using sharp instruments, especially in the area of internal carotid artery. So thank you for these tips and tricks, Professor Peng, and Raja, you can have the floor for the closing remarks.
Well, thank you very much. I'm extremely grateful to Professor Yong Peng and Professor Alberto Felitti for this wonderful session that we had, and special thanks to Professor Khalid Basim and Professor Stephen Florian, as well as Professor Shubin, who stayed back to hear both the session. We are extremely grateful. So now it's time I'll close this officially. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to thank both speakers of today, Professor Stephen Florian and Professor Peng Yong, as well as the chairs, Professor Khalid Basim and Professor Alberto Felitti, for the time and support for the ACNS webinars. I'm extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel, and as he mentioned earlier, there are around 730 people who have joined us live across all the streaming platforms. A special thanks to my co-host Liu Bun Seng for joining me today. So until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.